Good afternoon, everyone, and welcome to this afternoon's Black Health Trust. My name is Dr. Ivan Walks, and we are so glad that you are with us today. We will be discussing Be Safe for the Holidays with your family. The flu, RSV, and COVID are back. And now I'd like to turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone, and almost Merry Christmas. I think that's coming up very shortly.
I'm wearing the right sweater, Dr. Maxey, so yes.
Oh, good. I got to get me one of those kind of sweaters, man. So it's cold out here in California, too.
Stop it.
Yes, it is. Maybe not like you, but it's cold. So our topic today should be quite interesting. And I know everybody's getting ready to gather with their family and friends and loved ones. And that's what we want to talk about. So Simon, if you give me the ability to try to share my slides.
You're good to go.
Okay. Just a second. So we're going back to the older format where we started each program with the CDC data tracker. And as of this week, there were 99,705,095 cases. There's been 1 million plus deaths. The current hospitalization is 31,593. And we know that only 14.1% of people over 5 that have obtained the updated booster dose. So Dr. Walks and Dr. Hines, we haven't done very well as a nation with getting that booster dose up over 50%. I don't know why, do you?
I don't know why, Dr. Maxey. I have a lot of guesses, but it's just awful.
Yeah, so I'm thinking that misinformation still plays a part in what's going on. That's what I'm thinking. So the current scene, to paint a picture, the nation is still fighting to contain a month-long monkeypox outbreak. And polio continues to plague unvaccinated sectors of New York City. A riot of respiratory, I like that description, a riot of respiratory viruses may spread as temperatures cool down and people flock indoors. Importantly, the rates of RSV, respiratory syncytial virus, are also rising. And the flu has returned early. So maybe this is what they're calling the tridemic. So
that's what they're calling it.
Okay. So is Dr. Hines here yet?
I'm here.
Okay, because I know in your practice you deal with kids, right?
I do. Yep. The triple-demic is real. Like at schools and even in my own household, there were multiple people down at my house. Multiple people down.
Yeah, okay, that's good. I mean, that's not good, but
right. No, I understand, but no, it's real in the statistics and it's real in our lives. There's no cold medicine on the shelves. There's like people are out of school, activities are being canceled, rescheduled. It's actually happening, right? It's not just on paper. You're seeing it in various activities in your real lives.
Could you lead us through this slide?
Sure. So let's see, for pediatric patients, acute respiratory illness symptoms with suspected severe illness, Researchers suggest performing tests for influenza, SARS-CoV, and other respiratory viruses to identify, when there's more than one possible infection. One of the caveats to that that's a little bit tricky is there isn't really an in-home flu test, and there certainly isn't an at-home RSV test. Lots of us have access to in-home COVID tests, and you may have seen in the news too that they're going to start resending out free COVID tests. So sign up for that, similar as to how we did probably last year around this time. But there aren't really, you can't just go to the store and buy a flu test. And let's see, early detection is critical in identifying infections and co-infections because that can guide treatment. For example, flu, there are treatments for like Tamiflu and things like that, but they have to be used early on to be effective. And obviously we know there are COVID treatments available. And that's the RSV is kind of unique in that way. It's more of a supportive care kind of issue. The data gathered from 575 pediatric influenza-associated hospitalizations, including 32 patients who were co-infected with SARS-CoV-2. So essentially, just because somebody's sick and another person's sick doesn't mean they can commingle their sickness, because they may not necessarily have the same sickness. And then you can get double sickness. You can have flu and COVID at the same time. You can have RSV and COVID at the same time, which is rather unfortunate. The median age of the 32 children hospitalized in the previously referenced study were co-infected was 3 years old, and 4 were vaccinated against flu, and 19 were not vaccinated, while 5 were ineligible. Just anecdotally, in the context of vaccination, for example, my son had the flu in October before his flu shot. My daughter has the flu; she got her flu shot. So the shots don't say abandon your preventative practices. The CDC has warned about co-infection and the more serious illness that can present, and that needs to be tracked. The surveillance data for 2021-2022 flu season reveals that 6% of the flu-related hospitalizations and 16% of the flu-related deaths involving children were co-infected with COVID-19. The data is also showing that the rate of rise in flu is significantly higher at this point in the year than it has been in prior years as well. And of the 7 co-infected children who died, none had received the flu shot, although 6 were eligible. And these findings are according to the Morbidity and Mortality Weekly. Let's see, co-infected children were more likely to require bi-level positive airway pressure or continuous positive airway pressure. That is basically saying that they were more likely to need breathing assistance with things like CPAP and things like that, due to the severity of their illness. That's what they're talking about with the bi-level and the continuous positive airway pressure. We know that commonly a CPAP, the same kind of device that's used for sleep apnea, which we found also to be helpful with COVID infections as well. Compared to those who only had the flu, 16% versus 6% respectively. And they were also more likely to need invasive medical ventilation. Invasive medical ventilation would be literally when you have to put a breathing tube into your throat and use a machine to physically assist your lungs with the inhale and exhalation process. Influenza antivirals were underutilized, particularly among persons aged less than 18 years old with influenza virus and SARS co-infections who died. So when you're talking about flu antivirals, usually what will happen is, you get the diagnosis of the flu. Usually someone's going to ask you, the provider who identified that you have the flu is going to ask you about whether or not your person, whether it's a child or whatever, has certain risk factors, or if they live in the home with somebody who has certain risk factors. And that's usually a part of the decision-making process with regard to whether or not to use some of the antivirals. So for example, if you don't have any of the things that, if you get diagnosed, for example, with the flu, but you don't have any of the criteria that would suggest that you are high risk, there's a high likelihood that they're not going to say, here, take this Tamiflu, right? They're going to say, all right, supportive measures, and this thing is going to ride it out. Versus if you say, I've got the flu and I also live at home with my grandmother who has cancer, then you're more likely to get antivirals for the flu. And as this study says, only 1 of the 7 children who died had been given influenza antivirals.
So is that suggesting that the antivirals should be used anyway? Or can you really differentiate between the co-infection?
So you to differentiate between co-infection, you'd have to test for multiple. The good thing about that is they now have swabs that will do flu and COVID together, same swab, right? So, because again, especially when we're talking about kids, trying to do 3 different swabs on an irritated, angry 3-year-old is difficult. So it is helpful that they have now got, swabs that can do multiple tests off one thing. No, when we're talking about from a mass perspective, there isn't necessarily an overall benefit to just saying, here, everybody take Tamiflu, right? In the same way that even COVID medications have a stratification as well. It's not everybody run out because you've got a COVID infection and get X, Y, and Z. There are stratifications for a reason, because there are potential side effects, risks, and benefits associated with everything. And then for most people, that's going to work out fine. There are always going to be outliers who we didn't see that coming, or we didn't know you had, or, who knew that despite not having a high risk factor, you were going to display severe illness. We've seen that in all of these disease process. We've seen that in influenza, RSV prior to COVID, and we've seen that in COVID. So we're certainly going to continue to see that. I think recommendations are that for a reason, because they are a standard protocol that's going to fit most people, but there are always going to be some people who fall outside of that. And oftentimes that's where your primary care provider may have some discretion to be able to say, I know you, right? I've seen you and I know how you tank. Like, I know that we have a history together that says you'll be fine 1 minute and not the next. So because of that, we might do something different than what the protocols suggest.
So the operant word of what you're saying, that everybody needs to see their primary care physician or pediatrician. This is not a time just to be going to urgent care.
Absolutely. And that's why the relationships matter. The ideally, the longer you have an opportunity to be engaged with your pediatricians or your primary care providers, they're able to kind of, same as you, right? You've had your body, or you've been your parent of your kid for however long, that sometimes I hear you, but 99.9 is a fever for me, right? Like, I've had many people tell me that that's a fever for them, or that's atypical for them, or that's elevated blood pressure for them. And you have to respect that, have a healthy respect for what people know about their bodies and their situations. Mm-hmm. And when you have a relationship with somebody, they're able to take that information in a different way than somebody, for example, who, I've never seen you before. You walked in, you're the 17th person I've seen. We're trying to move this along. And it's not bad, right? Because for most people, the algorithms, the processes and things are going to work out fine. But there are nuances to healthcare. That's why it's called the art of medicine.
So I'm an internist, and I have people all the time calling me to see, we see my 12-year-old, my 16-year-olds. I said, no, I put an adjective in front of it. I will not do it because I don't know what is going on with them. Tell them who should kids see, and what are kids? What are their age? What's their age?
So there are some people who trying to pretend that kids are just little adults, right? Like, oh, I'll just give you a lower dose, right? And that's how we'll adjust for your kidness, right? Because here's the other thing: there's some big kids out there who are the size of adults. But there's more to pediatric care and pediatric medicine than just, do you look like an adult? So who should see kids? People who are trained to see kids are the people that should see kids, not just the next available warm body and person with a good functioning brain and a heartbeat, right? So whether that's your pediatrician, whether or not your family practice folks, your med peds people, whoever's trained to see pediatrics or to see pediatric patients, that's who should be seeing your pediatric patients. The 18 to 21 range can get a little tricky, but if we're talking your 12-year-olds, your 9-year-olds, even if they are 5'10" and 180 pounds, need to see somebody who knows what the protocols and the recommendations are for a child, even if they have a mustache.
Thank you. That's very important to me. I do not, I'm afraid of kids myself. So this is the last in our pediatric section, I think.
Let's see here. The consequences of this infectious churns are already starting to play out in Jackson, Mississippi. Healthcare workers are watching SARS-CoV and other respiratory viruses tear through children like nothing we've seen before. And as I said earlier, that's playing out across the country. And flu season has yet to get into full swing. The real depth of flu season is usually kind of that December to February timeframe. So for us to be seeing the kind of numbers that we've already seen in October and November suggests that this is going to be a serious flu season. And some of these kids are being slammed with one virus after another, and with their sicknesses separated by a few weeks. Again, that's already playing out in schools. Like you're already seeing that. Let's see.
So I think, again, the operant word is people should have physicians trained to treat their kids, whether it's a family practitioner or a pediatrician. But it should not necessarily be those of us who consider ourselves internists only. But there's a group of internists they're double boarded in both medicine and pediatrics.
Yeah, med-peds. Yeah, that's what medicine, pediatrics. Yeah.
Yeah. So, but make sure your kids see somebody that they develop a relationship with. I can't emphasize that. I always think of Dr. Wilbur Jordan. Every week he tells that everybody should have a primary care doctor.
Mhm.
Yeah. It's more than just, did my kid get their vaccinations and are they ready to either attend school and go to sports, right? There's more to it than just those things. Even when you're beyond the age of vaccinations, oftentimes people tend to fall off with their pediatric care of their kids when their kids are in that window where they're not needing shots anymore. Because they're up to date on all of their shots. But there's more in the same way, there's more to your adult care than just, your mammograms and colonoscopies, right? The same thing is true of your kids.
Are there any questions in the chat or points, anybody that we need to address at this point?
While we're looking at the chat, Dr. Maxey, I just wanted to add that, again, as with everything else we're talking about, there's more to your health than going to the doctor. So healthy diet, getting plenty of rest, making sure that you are as healthy as you can be before something comes that's trying to get you, whether it's COVID-2, whether it's SARS, whether it's RSV. A healthy body is still your best defense against whatever's trying to come get you.
Dr. Walks asked me what I had for dinner last night.
Oh, Dr. Maxey, we talked about you in this Popeye's chicken sandwich. What did you have for dinner last night?
I had a baked cauliflower seasoned with balsamic vinegar and marjoram, and I had some baked Brussels sprouts, and I had sweet potatoes and water to drink, and it was so good.
Dr. Maxey, you saying how good that was is like you telling me how cold it is in California. Okay. It's come on, man. It's Saturday night. You can't, but okay, seriously, that sounds like a great dinner and we should all eat that way. Absolutely.
Okay. So just an offhand thing here. A lot of people have avoided having elective surgery and other surgeries while the pandemic was going on. But a recent article followed a number of patients. A study showed that those who had surgery after COVID infection had more problems. But and most of the average of those people that underwent that type of surgery was about 90 days. So if you had a recent infection, it might be significant unless it's emergency surgery to try to delay that at least 90 days. That was just a point. So we're going to talk a little bit about how to protect yourself. And we know that winter is no joke. And we know that people do more things inside the house, gathered with people. And we want to talk about some of that. And Dr. Walker, would you mind leading us through some of these?
No. Winter COVID-19, no guarantee. With reinfection, it's all over the map. Chair of emergency medicine, by large, it seems milder, but again, there's no guarantee. Just anecdotally, I talked with a patient this past week who had COVID-19 this summer, got COVID-19 again at a post-Friendsgiving gathering where 10 people got sick. And this person who is under the age of 40 wound up in the hospital needing respiratory support. So there's no guarantee that you won't have a challenge with it. And there's no guarantee that just because most people are over this age or over that you may not have a challenging outcome. So no guarantee is a wonderful title for this slide. Here's what might happen during your reinfection, with an emphasis on the word might. With immunity from vaccines and previous infections, timing is key. If you recover from a COVID infection, you'll emerge with antibodies in your system that will, quotes, keep a lookout for future infection. Not all of them will help your body fight the next infection. Staying up to date with your COVID vaccines puts you at a decreased risk of severe illness. Again, decreased risk, no guarantees. Up to date means completing your primary series and receiving your boosters for which you are eligible. And we've gone over previously the timing of those boosters. You can always check with your doctor, the pharmacies. People will tell you what the timing is to get that next booster. And as we said earlier, the overwhelming majority of adults and kids have not had their up-to-date boosters. So both of those factors, the timing and getting your primary series and your boosters, all of that will help prevent reinfection, but neither of them can guarantee you won't get sick again, nor can they guarantee mild symptoms if you do. That's what I was trying to convey earlier. No vaccine or natural immunity is 100% effective, and these COVID immunity boosts generally last about 3 to 4 months before optimal protection begins to recede. If it's been a while since your last vaccine dose or infection, you may not benefit as much from your immune system's symptom fighting defenses. So
one of the
Dr.
things,
Maxey, so that means that even though you boost your immune system, it kind of wears off after a while?
well, that's true. That's true. And not only that, I was right before I went to the NMA, I was given an injection of something called Evil Shield. And I went to the NMA and I just knew I had a defense system all over. What's that thing they have over Israel, the Iron Shield?
Yes.
So it just came out from the CDC and the FDA that Evil Shield is not effective. And a few weeks later, I ended up with COVID. So we have to keep up to date with what is working and what is not working. All this is a work in progress. So what's good today may be proven not good next month. So we got to keep up. So that's very, very important that we do that.
So Dr. Maxey, I'm going to get you some new carry-on luggage so you can carry that virus killing machine that you have at home. You can just take it on the road with you.
Yeah, I think Mr. Dorsey said there's one you can wear around your neck. I'm going to get that.
He did say that. So
Okay.
Omicron is a different experience than previous COVID variants. If you get COVID, you'll likely experience the virus's Omicron strain or one of its subvariants. It's a family of them. The Omicron family currently makes up practically all US cases, with BA.5 accounting for 81.3% of them, according to the latest data. Omicron and its subvariants generally appear to be less severe, cause less severe symptoms than previous COVID variants. This could partially be because Americans are more protected with vaccines and previous infections than ever before. So if you first got COVID before Omicron emerged in November of 2021, a reinfection may be more mild the second time around. But a mild infection from the Omicron family still isn't a walk in the park, even for people who are otherwise healthy and vaccinated, causing sore throats, headaches, fatigue, coughs, nasal congestion, muscle aches that can last for days at a time. And I will add to this slide, allowing you to infect other people around you, such as folks who are immunocompromised, folks who are elderly. So again, it's not a walk in the park because, oh, I've had COVID, I got Omicron, I'm not feeling very sick. Let me just go on out to do my shopping and go to church and other places.
Well, I think that's very important. So it's still out there. It's still out there.
Okay, how to protect yourself against reinfection. Experts suggest increasing your protection against reinfection by getting an Omicron-specific COVID booster, which targets both the original COVID strain and the Omicron BA.4 and BA.5 subvariants. And we talked about the bivalent booster, the more recent booster. We've talked about that previously on Black Health Trust quite a bit. You can also reduce your risk of getting infected by avoiding crowded indoor places and wearing a mask indoors if COVID is spreading at a high level in your area. Or if you're smart, I wear my mask indoors wherever I go. So I guess that means I'm smart, Dr. Maxey.
I think so, Dr. Walk.
Thank you, sir.
You
Using the CDC.
You
Go ahead,
take
Dr.
less
Hines.
Thursdays than I do.
But to your point about masks, though, Dr. Walks, I think that a lot of folks across the country got a little bit more comfortable, right? When mask mandates and things like that were rescinded, when some of the signs came down at your stores and things like that, to say that the masks were not required. But the reality is, if we, as unpleasant as it may have been to wear the mask, they did help, right? Like we all saw that we weren't getting quite as sick as before. So even though it may not be a requirement to wear your mask indoors, if for no other reason than the same thing that prevents COVID, prevents the flu, and prevents RSV, you're getting even more bang from your buck from the same mask that you had, before. And we're talking about disease prevention.
Well, and it's important. Sometimes we'll be out in public in the store, for example, and they have the little stickers on the floor to maintain social distance, and the stickers are still there, but I'm in line and people are right up behind me. I turn around and I look down like, why are you right behind me? There are two of us in line and you are right. No one's going to cut in front of you. Just back up a little bit. So I just think it's everyone, and I understand, everyone is anxious to get back to the good old days when we could all crowd up against each other and we could, it's just not necessary for you to stand in line right behind the person in front of you who is not wearing a mask and is coughing. I don't understand why we get close to people that are coughing and blowing their nose. I've never, Dr. Maxey, stop that. I've never wanted to be right up against somebody who clearly wasn't doing well. And now it's, it's scary. It really is scary because people get very sick. And those of us, especially who are physicians and talk with people who are sick, we understand that people get really sick now. And it's just a useful thing to pay attention to your surroundings. So the last couple of bullets on this slide, use the CDC's data tracker to check for local infection and hospitalization rates. It's just good to know your surroundings. It's not inevitable that some people will experience reinfection. There are a lot of things people can still do, as we've just been talking about, to protect themselves against reinfection, to protect themselves against. A lot of folks have been inside for a couple of years now, and this could be your first infection with COVID, and certainly your first infection with COVID and flu at the same time. So just continue to be diligent.
But one of the things that I've adopted now, I don't shake hands anymore. I do a fist bump it with anything. But a lot of people use their hand to cover their mouth when they cough.
They do.
So hands are not very sanitary. What do you think, Dr. Hind?
Oh, I agree. And I would also just say that I think that one of the things that I hope stays around is that space where people give you a little bit of space in the line, because it does not make the line go any faster. Being next to me and being super close does not make the line go any faster. It doesn't, like, can you back up? I didn't need you that close to me before. So I love the space where, like, we can get some room. Like, let's just move on.
Right. So how to protect yourself? Experts say most people should get the new booster as soon as possible, particularly ahead of late fall and winter months when cases are expected to surge. So yes, and we are already in late fall. Winter starts next week and cases have surged and are surging. Vaccine protection slowly ramps up over 2 to 3 weeks post-injection. That protection typically lasts about 3 or 4 months before beginning to wane. So again, think about timing. You can't just go get your vaccine and then head off to grandma's house the next day. Well, I'm leaving on Friday. Let me get my vaccine on Wednesday. Not really a good timing strategy. There's no perfect singular date for booking your booster appointment. It depends on when you last got a COVID vaccine, how recently you were infected with COVID, and whether you're at high risk of severe illness from the virus. That whole last bullet, again, emphasizes why it's important to have a primary care doctor, someone that you can call, and a good place to get information. If you haven't gotten a COVID infection or vaccine in recent months, Pfizer's reformulated shot is authorized for people ages 12 and up. Moderna's new shot is for people ages 18 and up. And when we're talking about the new shot, we're talking about that bivalent booster that gets the newer strains or newer versions of the COVID virus. If you feel any side effects from the new booster, they'll probably be familiar ones similar to your previous COVID vaccine experiences. You could aim to schedule your appointment for a Friday or Saturday, setting aside at least one weekend date for recovery of whatever symptoms you get. It's safe to get your flu shot at the same time as your COVID booster.
I think those are some extremely important points on that. One of the things I noticed as an aside that both Pfizer and Moderna have put out their new pricing. So when these things aren't paid for by the government anymore, they're going to soak people. So we should know that. So it's better you get in line now, socially distance behind Dr. Walks.
Please.
And get your vaccine. That is so important that we do this early rather than late, especially with Christmas coming.
Before we move to the next one, just a couple of things in the chat that are relevant to some of the things that we've just discussed. Dr. Johnson posted a link to the CDC data tracker so that you can get information about COVID stats in your area. And Stephen Thomas made a comment around all masks not being equal. And just to reiterate that, when we're talking about putting masks on, I think what we learned previously from COVID was just because there's something covering your face, it's not necessarily always equal. So the KN95s and the like are, probably up there in the in the gold standard if you can't get an official N95 that's been form fitted, fitted and tested for your face, that kind of thing. But remember, they have the filters in there, so you can still be cute, right? You can still put your masks on Etsy that say whatever messaging you want to have and all of that kind of stuff. And they have the filters that you can put in there that can increase the effectiveness, so you don't have to sacrifice your fashion, right? For your health. You can do both.
Is that Dr. Stephen Thomas from Maryland? If it is, can you unmute him a second? I guess it's not. Do you see him, Dr. Hines or Dr. Walks?
I see Stephen B. Thomas. Is that the
That
Dr.
should be
Thomas you're
him.
thinking about?
It doesn't have a picture of a person. It just has an image.
Can you unmute him, Simon? He runs a major health information center at University of Maryland.
It has a couple of what look like barbershop poles, and I think that's a reference to my need to get to the barbershop.
It's all right.
Myself.
You're a week out, right? You gotta wait. You're in that window. If you go too soon, it won't be sharp for Christmas, right? Like you're in that window.
Simon, can you
Gotta get
unmute
myself
him
lined up.
if it's possible?
I sent the request. He has to click the button.
Okay. In the meantime, let's go ahead and do it. Any other comments in there, Dr. Hines? No questions?
No other questions. Just Dr. Johnson then laid out the distribution of the variants, the COVID variants that are currently laid out, where BQ 1.1 is 38% of what's circulating. BQ 0.1 is 31% of what's circulating. BA 0.5 is 10%. And XBB is 7.2%. But again, I think certainly you can link to the data tracker to figure out what's going on in your.
So Dr. Johnson has a new book out. Can you unmute her for just a moment? Dr. Rhonda Johnson? Nobody wants to talk today.
There's Dr. Johnson.
Hello, Dr. Maxey.
Hello,
I was
Dr. Johnson.
trying to run and turn my television down. The Steelers are playing the North Carolina Panthers, so I got the football game on.
Okay, okay. So I know you always give us good information. I know you also have a new book out.
Yes, I do. I have a book out. My book is called My Journey. And I talk about being an educator on social media. And I share the experience of 3 years of posting health information on YouTube, Facebook, Instagram, and TikTok. And I try to share the voices of the people who followed me on these various platforms, because it really does give a snapshot of the human behavioral component to this pandemic. It shows the trust, it shows how people are looking for a trusted messenger. It also shows the enormous amount of mistrust out there. It highlights the people, real people, and their experience coping with this pandemic. The lack of information, reliable information, is huge for some people because, the pandemic is not covered like it used to be on network television. So I hope that people will take a look at it. I will share the link. I self-published it on Amazon, so it's available on Amazon and Kindle, paperback, and hard copy format.
And maybe we'll be graced with your presentation to the Black Health Trust sometime in January. We'd love to have you.
Okay, well, thank you.
Okay, Dr. Walks?
Okay, absolutely. This slide is how to protect yourself. CDC advisors say you should consider waiting 3 months after testing negative before getting your new booster. Studies have shown that waiting a few months after an infection to get vaccinated can result in a stronger immune response from a vaccination shot. CDC website says people who were recently infected also have a lower risk of reinfection, the agency adds. If you're elderly, immunocompromised, or otherwise at high risk of severe COVID. If you're at high risk of severe illness, JA recommends getting your new booster right away. Is that Dr. JA, the White House COVID advisor, Dr. Maxey?
Right. Yes.
Okay. And this recommendation includes people who are elderly or immunocompromised and those with underlying medical conditions. And I'll just say, as someone with a 90-year-old mom, you be the one that protects someone who is a senior person to you. Don't expect that all of our seniors are online, getting the latest information from Dr. Johnson on TikTok, or that they're checking the CDC website to find out what's happening in the community. A lot of folks are depending on us to behave in a way that protects them. So just because grandma says, hey, come on over, I'm baking that pie for Christmas, doesn't mean you can just recklessly run over there with no vaccination, no mask, and no care. It's important for us to think about others as we celebrate the holidays.
Simon, can you share the slides? Okay, so we've put some subjects out there that people need to know coming up on Christmas. And let's kick it around just a little bit. We have just a few more minutes, but I want to make sure that we have given our best to protect ourselves and our audience from what they are going to be going through starting next Saturday night, I guess, right?
Yes, sir. You know, one thing, Dr. Maxey, that we haven't touched on today is just the traveling that folks are going to be doing. A lot of people are crowded together in airports. I remember at the start of the pandemic, I was flying from California back to Maryland, and it was a late night flight. There was one gate open with one late night red eye, and the airlines had everybody crowded into that one gate area. And I couldn't understand why there wasn't any sort of an announcement asking people to spread out or something, because we just can't depend on folks who are in charge of things to be thinking that way. So be aware. I think Dr. Hines made the point earlier that just getting all up behind somebody doesn't make the line move any faster. Well, getting all up behind somebody doesn't make the airplane leave any faster. So I found myself, standing back. I can wait and get into my seat for a cross-country flight just before they close the door. It's fine. As a matter of fact, it might help out the sitting in the seat for 5 hours worrying about getting DVTs, getting blood clots. So there's something about being able to walk to the other end of the terminal and back a few times, get some exercise, get things loosened up before you go and get in line and get on the plane. I don't see why people want to sit in that seat with everybody around them and crowd up in those lines before they sit down with those same people for 5.5 hours. Makes no sense to me. So just kind of be thoughtful about keeping that space, making sure that and those of us who wear glasses, every time you look down, the glasses fog up. Wear your mask anyway. I have a challenge, a personal challenge with keeping my mask on and keeping my glasses from fogging up. I don't know. People try to help me, but I still can't get it right. But I still wear my mask.
Go to sleep, Dr. Walks. So
what, you don't notice, right? In the chat, Dr. Gibson put a pseudo question I was going to say about the immunocompromised. And I think that just to review what immunocompromised means, there are absolutely some people who have immune conditions that maybe they've had for their whole lives, right? So, maybe they know that they're lacking, white blood cells, and they've adjusted to that, known that likely for their whole lives. Then there are some other things. So, for example, there are medications that maybe you might take for things like psoriasis or MS, or even, severe asthma or COPD. Steroids are a prime example, where the disease itself does not necessarily mean that you are immunocompromised or that your immune system is not in tip-top shape, but some of the medications that are using to treat some of these other conditions have the potential side effect of weakening your immune system. And they're going to be some of those same medications that they'll say, make sure you get a TB test, make sure you check for if you've had hepatitis in the past. Some of these conditions that when you took the medicine, you had to check to see if you had any other diseases that might be awakened by the use of some of these medicines. So when you are evaluating where you think your risk is or where you think your risks are in that space, just being mindful that sometimes some of the other things that you take can put you at risk, in this case, for not being able to optimally adjust to COVID and the flu. Some of the other ones are the cancers and things like that. Even without treatment, just by nature of having the cancers, that then puts you in an immunocompromised position. That having diabetes is considered an immune compromised condition. So that's a very common one that people don't necessarily see that way, but you get to check the box.
One of the biggest things is senior citizen status.
Yeah, that's true too. Yeah.
So this ought to be a word to all of us. As you get older, your immune system is less competent. And I think in general that we should think about being in a community of color, that we may have some unknown thing that makes our immune system. Now, there's not only immune system compromised, but there's certain genetic modifications. We'll talk about those in the near future that have happened that make you less immunocompetent as we go forward. I noticed Dr. Exliner Bean, I don't know if she can unmute, but she's a chief of pediatrics at, not Morehouse, in Tennessee, Meharry. And we talked early on about some of the pediatric challenges with differentiating between co-infections like flu, as well as COVID and RSV. And I'm sure she's seeing a lot of that. Dr. Bean, are you available?
You're right. We've seen a lot of co-infection with influenza and RSV. In fact, we're seeing reinfections. We keep trying to explain to people, and some of that's been discussed already related to boosters for COVID, that even if you get influenza, you actually should still get your influenza shot a couple of months later, similar to what you should do with COVID. And so with children, we're seeing a lot of kids who are coming in with influenza more than one time, just as you're seeing with adults who are coming in with reinfection with COVID. And that's one of those issues which most of our parents don't understand. If I had the flu, why didn't you get the shot? Now, we won't even discuss the fact of this major problem we have, especially in the African-American community, with taking the influenza vaccine from the beginning. One vaccine that we know has been proven to be very efficacious for years. The issue of COVID is different. And interestingly enough, I now have parents who refused the influenza in the past, who now want influenza because they somehow think that they're going to be protecting their kids or themselves against COVID. And they are two very different vaccines. So education is an extremely important thing for our community. The other thing, which I think is going to be a real problem, so we talked about that at one point, and it's gotten to be less of a problem now, but getting Tamiflu, which is the PO version of it for children, there is every single year, there has been a shortage of that drug for pediatric population. And so at the beginning of the flu season, it was like we had a major shortage of the drug. It seems to be a little bit more available at this point, but for example, in Nashville, at one point, every Walgreens was out of Tamiflu. And I don't know if they had the same kind of a problem in LA or some of the other parts of the country, but they seem to be doing a little bit better. And the other thing we've also seen is a lot of co-infection with strep as well. And all of these are related to the fact that we have gotten rid of the mask mandate in most schools at this point. So a lot of these problems that we didn't see last year or the year before, we're beginning to see again. So yes, you can be co-infected with RSV, which we all know, but you can also be co-infected with other problems, and specifically in children, we've seen an increase in the incidence of strep. The thing that I think is going to be finally that is worth discussing is the public health implications, especially for our communities, of the expiration of the emergency authorization. And it has been mentioned, which is supposed to occur someplace around January. What's going to happen when we are no longer, we've already gotten notice from many of the insurance companies, when it's no longer automatically are they paying for the COVID testing. And we, like a lot of places, we do both COVID and influenza tests. We do one test at the same time. RSV is a little bit more complicated. But at this point, it's going to be really interesting to see, and I don't know what that's going to happen, is when people would have to pay for testing, whether the insurance companies are going to pay for testing, whether Medicaid is going to pay for testing. I anticipate that Medicare will pay for testing and that there will not be a problem with testing for older Americans. But I do have some concerns, and significant concern is that, yes, it's the usual form of strep that we're seeing, strep A.
Let me bring up a question you caught, a bone that I have. I'm so concerned that in our community, especially the patients I see, if the insurance company or the government doesn't pay for something, they won't get it. But come New Year's Eve, they're going to have some champagne no matter what. So we have smart choices that we have to be able to say, if somebody doesn't pay for it, but it can save your family's life, I think you should get it.
No, I agree. But I really think there is going to be a public health issue when, number one, if they're not going to pay for the testing, and two, what happens if they're now saying they're not going to pay for the vaccine? I think certain populations, special populations, they'll have to consider to pay for the vaccine, but those populations are not necessarily the populations which it turned out we suddenly discovered disparities. Healthcare disparities.
And I'm
going to continue.
We also have food deserts where you can't get good food. I believe we also have medication deserts where all the pharmacies in certain areas don't appropriately serve the communities. And I've seen that happen, especially in the areas that I practice in. We also, Dr. Bean, I really appreciate you, and just like Dr. Johnson, I want to hear from you in January to come back with us at some point with your own presentation. We have another pediatric infectious disease doctor on the line, Dr. Sherrod. Do you have any comment on what about our kids and these infections? Okay, she may not be able to unmute.
Oh, good morning. Yeah, good morning, Dr. Maxey. Thank you for. I just have the statement that I've been saying over and over again. We are faced with a big challenge now with all three infections occurring simultaneously: the RSV, flu, and COVID. But I like to emphasize prevention, and in spite of your vaccinated status, your immune system, and you've emphasized that today, really determines the outcome from almost all of these infections. So we need to also emphasize, and I'll re-emphasize, eating properly, boosting, and people hate to hear you say that, but you have to boost your immune system because that is a major factor in your outcome. So people need to remember to get their vitamin D levels up to greater than 30. They're recommending now around 50 is more protective since the COVID pandemic. So make sure you're on your vitamin C, your vitamin D, zinc, quercetin. All of those work to improve your immune status so that if in case you get the infection, your body can fight more strongly.
So Dr. Sherrod, I recommend for patients during the height of the pandemic, I recommended 50,000 international units of vitamin D for 1 month straight, once a week. And then I cut it down to between 2,500 and 5,000 a day after that.
Mhm.
And do you agree with that dose being recommended? And 2,000 of vitamin C per day for adults?
Well, the general recommendation, Dr. Maxey, and I haven't had a lot of experience with those high doses, but I think the most important thing is to ask your doctor to do a vitamin D3 level. And that way you'll know what you're doing. But there is a book written by, and I forget his name now, he's at UCLA, on vitamin D, and he actually breaks it down by weight and what you need to do to get your vitamin D level up to 250.
Is that Dr. Keith?
It's not Dr. Keith Norris. It's actually, I can't think of his name right now, but I'll get the book and bring it on our next session. But it's generally recommended that you do 2,000 to 5,000 IUs per day. That's the maintenance dose, and then check your levels and make sure your levels are around 50. You don't worry about toxicity until you get to 100, if you get a level of 100. And actually, I keep my level around 80 because way before the pandemic, people with autoimmune diseases, is recommended that you keep your vitamin D level around 80. So you can take quite a bit, and I think you'll probably be okay with what you're doing. But the key thing is to check that vitamin D level. Have your doctor draw the blood for that.
Thank you very much. Dr. Gibson, do you have a comment as a senior pharmacist?
I resemble that remark. I have to say that it's a very timely comment that Dr. Sherrod just made about the importance of nutrition. I cannot emphasize enough how critical that is in terms of the body's natural immune protection. So if we can, and even if you think you don't have time, make time to put in a phone call or even walk up to your local pharmacist and have a conversation, because you have plenty of information that's readily available for you to just really take advantage of on a regular basis, because things change. One recurring theme I've heard today is things change. And when the facts change, guess what? We change our minds, we change our patterns of activity, and we change our behavior as far as the amount and fact of nutritional supplements that we take, and the types of foods that we take, and the amount of orange juice that we drink, and et cetera, et cetera. Thank you.
Thank you very much. Dr. Hines and Dr. Walsh, we need to probably make our final comments and get everybody back to doing their shopping. Dr. Hines, you have final comments?
Yeah, I was just going to say that there's a question about how often to check vitamin D levels. And it's going to depend, right? So you're going to find out where your baseline is, and then you and your primary care provider would establish what would be a regular cadence. Vitamin D not only comes from supplements, but it also comes from, sunlight and sun exposure, as well as, the different things in your diet. So if, for example, it's wintertime or approaching wintertime, the amount of, depending on where you live, the amount of time that you spend outside might significantly change over the next 2 to 3 months compared to where that might be, for example, in June or July, right? And that could certainly impact where your results are. Now, if, for example, you are found to have a vitamin D deficiency and you're on some of the higher dose supplements that Dr. Sherrod and Dr. Maxey were discussing, usually you would get retested in about 2 to 3 months. So the answer is that there's not one answer, right? The answer is going to be that you and your doctor would kind of work that out, because there are external factors that can cause natural kind of fluctuations and changes in your vitamin D level. Compared to what it might be if your routine, for example, wasn't going to change. If I was in an all around, if I lived in Florida and my routine doesn't necessarily change that much from June to March to December. Or if, for example, all of a sudden I'm going back to working indoors all the time, spending 10 hours a day inside, that's going to affect potentially your vitamin D levels. So,
Dr. Hayes,
Mhm.
why do communities of color tend to have lower vitamin D levels?
That's of the
Uh,
melon.
what'd you say, Dr. Shara?
Isn't it because of the melanin in your skin?
To a
Yes.
certain extent, that plays a part. Yes. Yeah.
I
Is there-
have the book, Dr. Maxey. It's called The Power of Vitamin D, and it's by Dr. Zaidi, Zaidi. I guess that's how you pronounce it. Safraz Zaidi. He's actually clinical professor at UCLA, and he has a brand new chapter on vitamin D and COVID-19. In this book, he breaks down the exact
in-
dosages.
Can you put it in the chat?
Yeah, I'll try to type it in. I'm technically challenged, but I'll type it in.
They say it clearly. Maybe somebody can put Simon or somebody.
Yeah,
Can put,
Power of Vitamin D by Dr. Safraz Zaidi, MD, UCLA.
and for anyway, we had a comprehensive lecture on vitamin D given by Dr. Keith Norris back last year. So maybe we can go back, and I know that's posted. And Dr. Keith Norris is one of the top vitamin D guys in the world. So I would expect people to go back and look at our library on that. Well, thank you so much, Dr. Hines. I appreciate you. When are you coming to California again?
Soon, actually. I'll be soon. So we'll talk. Yeah.
Okay, good. Dr. Ivan Walks.
So Dr. Maxey, there have been a lot of comments in the chat about healthy lifestyle. And I think beyond the physical health that we've talked about and the supplements and the vaccinations and what have you, mental health tends to be a challenge when things change. So we've seen a lot of increase in mental health challenges since the pandemic as folks have been isolated and kept inside. We also see that every year with this time of year. There's that seasonal affective disorder. People don't tend to be able to maintain that mood that we like to maintain during the winter time. And so there are lamps that folks can get to brighten up their workspaces and a lot of those kinds of things. So I just want to make sure that we keep the mental health part of our health prominent as we're thinking about what we need to do over the winter. And then the last thing I'll say, Dr. Maxey, is I made light of your dinner from last night. And you guys know I'm sort of irreverent and sort of joke around about things that aren't funny, as my wife reminds me all the time. What you said was very important. You talked about your broiled Brussels sprouts, and you talked about your cauliflower dinner, and you talked about how it was tasty. And I think we need to be willing in our community to look at some things that are different than what we would normally eat and think about the fact that when prepared well, that stuff is pretty darn tasty. It's pretty good. So if we can learn to enjoy food that is healthy for us, I think it's an absolutely important thing for us to do. As Dr. Gibson pointed out, when we know things different, we do things different. So it's like the old folks used to say, when you know better, son, you do better. Well, if we know better about the kinds of food that can keep us healthy and strengthen our immune system, we should be promoting those foods. So I apologize for joking about your dinner, Dr. Maxey, and I think it's important for you to share with us when you're doing well.
Well, thank you so much, Dr. Walks. And I may invite you to dinner one day to one of my healthy meals I've learned how to cook. You know, it's so easy now. I've got an iPhone and I go say, give me a recipe for this, give me a recipe for that. And they pull it up, and I love to cook. So my final word is, first of all, I do want to thank Dr. Ken Steiner for being online with us, even though I know he lives in New Hampshire. They must have about 12 feet of snow. Is that true, Dr. Steiner?
Yeah, not 12 feet. Good evening. Randall. No, but we got 12 inches to 16 inches here, and it's been really rough, but good to be with you all today, for sure.
Good to
Stay
have you.
warm.
Good to have you with us. I'm not going to visit you until the summer thaw.
Okay, you're always welcome. You know that.
Thanks so much. And thank you for your lovely gift that you sent me. So good. So for next Sunday, which is Christmas, and the following Sunday, which is New Year's, I want to have a program, but I want to make it very abbreviated, just to answer any burning questions. And I know everybody wants to celebrate with their families, but I don't want to cut us off. But also, starting with January, we've agreed to abbreviate our show to 1 hour, and also to make it 30 minutes later. So starting on January 1st, we'll start at 12:30. I'm sorry, what time did we say we'd do that, Dr. Walks? Was it
Dr.
half
Maxey,
hour?
I thought we said that we were going to go back an hour, but if we're going back a half an hour, that would
No,
make it 12:30 Pacific.
No,
and
an
that would
hour.
make it-
An hour would work. I think an hour was what
Hour
we.
would work. Okay, so that means 1 o'clock Pacific and 4 o'clock Eastern.
Okay. So we're gonna have 2 abbreviated programs on the 25th and on the 1st. And after that, we'll resume our 1 hour programs, but it'll be 1 hour at a later time. I'll make sure that's clear in the emails. And thank you very much, Simon, for being with us. You have a final word, Simon Cooper?
Make sure you use common sense when you're around your family, because not everybody in everybody's family uses common sense. So be that motivation and that inspiration.
And can you take 30 more seconds to describe the dinner that you and your mother fixed for me when I flew there from Jamaica?
Don't remember exactly what it was, but I'm sure it wasn't as healthy as it needed to be for you.
It was all live, all raw, nothing was cooked. I had a salad made with carrots and
Well,
gravy.
you have to thank your sister for that, because I had no part in the healthy aspect of the meal.
Oh, okay.
That's
All right.
that's not my bag.
I'm trying to give you credit. I'm sorry. Have a good day. Have a good day, everybody, and Merry Christmas and Happy Hanukkah. And we're glad everybody took the time to be with us today. Thanks a lot. Have a
Thanks,
good day.
everyone.
And thank you, Dr. Maxey.
Thank you.
Glenna Kelvin Tolbert, MD.